previous studies, and then we have collected the previous studies and I've done a meta-analysis, and I will summarize that briefly. The study is still ongoing. Okay, I have no conflicts of interest. Okay, relatively little is known about factors associated with long-term changes. There are several studies which have looked for short, weekly or monthly follow-ups on brain changes in schizophrenia. For instance, several clinical trials, but they are usually short-term trials. And its interest, of course, is illness which affects brain, or can it be medication, or both, or are there other factors also? Of course, there are changes which are not due to medication, that's very clear, because there are already brain structure changes in first episode patients. There's been a systematic review by Grant Steen in 2006, who found that whole brain and hippocampal volume are reduced and ventricular volume is increased in first episode patients already, indicating that there are changes in the brain already before the onset of illness. Regarding general factors affecting brain, there's been quite recent meta-review on the topic, and meta-review means that they have reviewed previous systemic reviews and meta-analysis. And this is a very useful study by Shepherd et al., and they conclude that there is not too much high-quality evidence regarding changes and factors relating to it, but especially rational alterations are, some are specifically related to illness states, and some are also to medication status. And there are a list of areas affected, and there are several studies, and some studies focus on certain areas, and some are more broad that they focus on in principle all possible areas. Regarding medications, first study which pointed out this possibility that maybe changes are not only because of illness, but medication could have a role, was already 1976. There's a letter to Lancet by Marsden pointing out that previous CT study finding that ventricular enlargement and schizophrenia changes compared to controls, that those changes could be due to the medication. First, modern study focusing on this MR study with the long term, in our case, I mean 2 years or as a clinical trial, this is still the only clinical trial having that long follow-up. That was by Lieberman, 2005, and they had several scans and quite large sample, 263 randomized patients, and they concluded differences between haloperidol and olanzapine. And their conclusion was that haloperidol could have some toxic effects, but olanzapine some therapeutic effects, maybe even neuroprotective. But this study has certain limitations, and by far those which are around certain there are statistical significant findings. There's one after 12 weeks which disappeared after 2 years, and one was worse than colored nucleus, and that was white matter, whole brain matter. But the problem there is the sample sizes. You may see that at the end of the 2-year follow-up, sample size in Halberg group was 10, and it was was originally 79, so there's a large possibility for bias there. And also in the large group, the sample size decreased from 82 to 24. Later on, also, naturalistic observational studies have been on this topic. This is a study by Hall and especially Nancy Andreasen, who is the second author. This is part of a very large Iowa longitudinal study. There's a 7-year follow-up, and there were several scans. On average, three scans during that time. And this study was the first concluding that maybe the effects could be so that actually it could be harmful for medication. This is the first study that's actually got some comments regarding, and this actually would be the case because what famous research group. And this is what they found when we compared antipsychotic treatment and illness severity. As you see, there are those highlighted are the statistical significant effects. So antipsychotic treatment had an effect on both frontal, temporal, parietal, and cerebral gray matter, and increasing effect on dopamine. And that has been found also previously, that there's some changes regarding movement, positive changes in dopamine. But illness severity also matters here. So in those cerebral and frontal gray matter, both treatment and illness severity affects, and this is so they are adjusted for each other, and also some other factors which are listed there. So research also look for different antipsychotics and different effects, and this is a table comparing typical non-clozapine atypicals and clozapine. And as you can see, there are different effects in different areas. Some are more consistent, like frontal gray matter decrease and dopamine increase related to the medications. Also, previous researchers have tried to review these studies. There are actually several, as you can see from the bottom of the slide. Some of the reviews are focused on very, for instance, included cross-sectional studies and studies with short follow-ups, or focused on, for instance, on basal ganglia or things like that. And basal ganglia increment is very clear, but also decreases in gray matter and global brain movement, and increments in CSF has been found. And regarding differences between typical and atypical, it's what unclear what are the differences, and it's to replicate some finds have been done. This is most recent extensive systematic review by Jouko. They looked several studies, but they focused on more like between study correlations. So they look for average decrease in the study population and average dose in the study population, how they correlate. So they study within studies how these correlate the changes. So they conclude that the memory decreases inversely correlated to the exposure to antipsychotic treatments. And and conclude also that schizophrenia is characterized by progressive gray matter volume decreases and lateral vertical volume increases, and some of these alterations may be associated with antipsychotic treatment. But this is different than our aim. So our aim was looking original studies and how they are within studies, what type of changes they have found and associations with medication. So this is our aim. And we systematically review longitudinal MR studies with that gives 2-year scan interval. And the idea is to look for dose, especially I propose in this presentation, this dose of antipsychotic medication and brain cognitive changes. And schizophrenia-related psychosis means here schizophrenic disorder, schizoaffective disorder, and delusional disorder. There are some studies also on other sides, but they are even fewer than in schizophrenia. So the study looked for 4 different databases, and we also got and asked data from authors of the original publications, so because there's some type of publication bias existing, of course. In some types they just report that medication didn't associate with brain changes, but we tried to look and ask for data also regarding these studies. The 2-year scan interval was correct, and the aim was to look for within study correlations between dose and changes in the brain volumes. We did look for all studies regarding systematic review, but for meta-analysis, we included only 3 studies reporting the results on these changes. I'm not going to details, but some studies reported correlations, some studies other statistics, but we did change these, try to estimate the results using correlations, so we did different transformations which are based not usually on normal distribution, so because the methods are quite heterogeneous in the studies. We did categorize brain regions to 10 regions which are listed there, and brain tissue types. Some studies look for gray matter, some white matter, some CSF, and some studies volume, so it was very difficult to compare all these, and some regarding brain regions, some studies look for some small areas, and so on, so it's not easy to combine all these. But we did try our best. So this is a list of studies. This is the first slide regarding the included studies. I already mentioned this Iowa study. This is by far the largest, up to over 200 people and 7-year follow-up. And they look for several areas, and there are the studies reviewed are listed there. And also in the Netherlands, there are very large project looking for these things. That's Utrecht Schizophrenia project. About 100 participants and 5-year follow-up. Also in Santander in Spain, there's a large study, 83 is the sample size and 3-year follow-up. And there's one Swedish sample, 5-year follow-up and sample size of 50. And in Chicago, USA, there's a study with 20 to 56 people, varies between reports, 2-year follow-up. And then at the bottom of the slide is our own study in London on 3rd quarter 1966, which we have 33 previously treated schizophrenia patients and 9-year follow-up. So our follow-up is actually longest about this here in the first page. So there's some studies like the Iowa's first episode study, and also the Santander study. Others 3 are previously treated patients. And of course, it's difference between these two, because in previously treated patients, it's possible that the brain changes have already happened, so one would expect maybe less changes. But on the other hand, they may have higher doses and so on. Can vary. These are the rest of the studies, and these are those with lower sample sizes. Maximum sample size here is 23, so it's quite small. Follow-ups are from 2 to even 10 years, and this is interesting also that these studies mainly focus on small areas and specific brain areas, maybe indicating possibility of publication bias, because small study, so you will not get easily statistical significant findings, and so that's of course a problem. But the studies are small, as I mentioned, and there are studies from UK, USA, Australia, Japan, and one study also, additional study from Netherlands. Okay, so the results. So the studies were often highly heterogeneous regarding methods, and also as you saw regarding selecting brain areas. And the focus was rarely on our topic, that is antipsychotic medication and brain changes. It could be general predictors for brain changes or illness-related predictors. Most of the correlations reported in the statistics are not significant, and in some cases it was clearly due to small samples because the correlations could be quite high, even 0.3 or 0.5, which is quite large effect already, but the sample sizes were small. There were no clear differences between typical and atypical effects. And regarding meta-analysis, we found two statistically significant correlations. There was a decrease in parietal lobe, which is surprising. There were 3 studies, and correlation mean minus 0.17. An increase in basal ganglia is expected, correlation 0.10, so a bit less. The 4 studies and significant finding. These are all the studies with all the analysis we did regarding the correlations. One comment regarding method is the random effect meta-analysis means that you will not wait for sample size, and this is usually done in this type of observational studies. In clinical trials, you would wait for the sample size, and then it's fixed effect meta-analysis. So with both are the significant correlations, which I already mentioned. But regarding other correlations, there were similar and in parietal lobe, similar decreases also in temporal lobe, frontal lobe, and total brain volumes. But in these areas, the large heterogeneity made it that so that these were not statistically significant. In cerebellum, there were no changes, and in basal ganglia, there were no heterogeneous effects. One was quite robust. We also, there were several studies which did not report the correlation test data, they were non-significant. We also included these and repeated these analyses, so we included those as zeros, and the results of significances were the same. So that was no effect on that. Okay, so there were heterogeneous methods and findings. One comment regarding these long-term studies from 2 to 10 years is, of course, are they of good quality, because it's not easy to compare different brain scans because the scanners may change, scanner settings may change, and so on. Many studies did not use any covariates, and the study I showed in the beginning by Andreasen and Hall, that was one of the very few which had large enough sample size also to look for this. We will continue to do this, and hopefully more studies will be included. Then regarding some other studies and which are still ongoing, our own sample, we have looked already for total brain volumes and some other volumes. So we have also here the poster presentation on this topic by Sanna Hutrenska. So our sample is a third cohort, and with the 9-year follow-up and sample size of 33. This is the published results by Professor Jouko, and we found that both typical and atypical medications and any antipsychotic medication dose associated with ranges quite robustly, regardless of covariates, and there were total banks, meaning total psychic symptoms. We also look for if alcohol use affects or weight change, which have been also linked with weight changes. And also SOFAS, which has a measurement of social and occupational function. Did that only a small effect on the associations? Of course, sample size is quite small, so it's not so as easy to assess as it would the larger sample size. This is poster by Sana, you can see that in the afternoon module, and those are those significant regions we found. So antipsychotic medication associated with ventricle sizes, increases in ventricles and decreases in total gray matter, and also right accoutrements and left accoutrements. So there were 15 areas studied, and 5 of these were associations were significant. We will later on focus on look for more covariates regarding these findings. This makes some idea about the original changes can be in different areas. There is also one new study by Andreasen which did not focus on antipsychotic medication, but anyway, it did focus in some way, but looked also relapse duration, because of course, in clinically thinking, reducing doses of antipsychotic medication, it's of course important that we think about possible consequences of these. So they looked in one study, compared relapse duration, treatment intensity, and how these two things associate with brain changes. They conclude that extended periods of relapse may have negative effect on brain integrity in schizophrenia. And these are the findings regarding relapse duration, and they found that it has an effect on total cerebral lobes, total frontal lobe, white matter in frontal lobe, and white matter in temporal lobe. Whereas at the same time, antipsychotic medication has some similar effects on cerebral, total lobe, and frontal lobe, total lobe, additional in some other areas. As you can see, both have effects, so it's important to have some kind of balance between these. I noticed this review also. There's some studies also bipolar disorder, finding that they conclude here that psychotropic medications actually they don't have negative effect, and in this case, of course, it's mainly lithium which may have even some kind of positive effect, but it's not negative effect. So it's not only negative effects which have been linked with medications. Okay, to conclude, so the main message is antipsychotic medication may contribute changes in brain structure in some areas of the brain. Of course, more good studies are needed, and maybe also comparing samples, because it's difficult to study. And main problem I see nowadays is publication bias, because only significant findings are published, and maybe even it can be biased based on what they find in some cases, maybe negative effects of medications are not published so easily, and it can be also vice versa. And of course, blood samples are needed also to look for potential covariates like cerebral illness, substance abuse, smoking, duration of illness. Of course, some genetic markers may have different effects, and in combination with other factors. And one crucial thing is also, although we find these findings regarding structural changes, what are the actual meaning regarding, for instance, cognition or functioning in general? There are, of course, studies looking for also antipsychotic medication cognition, and they have found also negative effects regarding that. But mainly it can be also that it is some kind of treatment resistant, which means that there's some combination or explaining explanation regarding that. Okay, this is our study group, and as I want to thank Sanna Uuttonen, is the director student, and Erika Jääskelä, who's the second supervisor of Sanna. And thank you all for listening. Do you have any questions, please?
Thank you very much for your interesting talk about meta-analysis. Thank you for your presentation. I was wondering, of course, there are all reasons to do research about brain volume and antipsychotics, but I'm very curious about your vision. Why is it important to know whether or not brain changes are being found by antipsychotics for clinical practice? So I'm very curious about your
Yeah, good point. Because many of them treatment, well, the point is first that treatment guidelines usually, the idea is that you would treat with a minimum effective dose. But I see that it's not usually or often the case. So that's one way also to encourage to follow treatment guidelines. The one is interesting also is regarding treatment resistance, that you just not increase the dose if you don't see the effect, because the increase of dose may have negative effects. So those are the main points regarding clinical work. That's a very good question.
So you mean not harming when that's necessary?
Sorry?
Not harming, so not doses because it's unnecessary.
Of course, it can be necessary also. We can learn more about this maybe later regarding, for instance, treatment-resistant schizophrenia. But when it's not necessary, that's the point, of course.
Thank you very much.
Yes?
It seems it would be exceedingly difficult it would be exceedingly difficult, if not impossible, to actually differentiate between changes that are caused by the illness and those that are caused by the medication.
That's an excellent point, and of course, those studies which I showed previously, especially this Andreasen study, did try that, as I showed before, and this means that there are some the both effect, of course, and these are trying to estimate adjust for each other. So that's a good question. And there are some errors, of course, but if you think that medication isn't working, that means that you are taking both these effects. So you are still having symptoms because the medication doesn't work. You are having also medication, so there are both these effects are there. But of course, if you are able to treat the symptoms with the good medications, then of course you are less harmful effects.
But we also know that almost in 60% of patients, the medication don't work anyway.
Yeah.
And symptom reduction is not 100%.
Yeah.
And we do know that at least this seems to be more of a problem with the older agents. Agents like olanzapine and lithium actually are shown to increase brain volumes, from what I know.
Yeah, that's a good point.
Thanks.
You've mentioned the prospective study. You've mentioned the prospective study, and that was showing major effects in white matter, whereas in those studies, the major effects are in gray matter. So, could you comment on these differences?
That's a good comment. I think changes in gray matter are a bit more robust, I think, regarding these long-run studies. There are effects also and findings regarding white matter. I don't have here slides regarding all those significant findings we found, but I think there are more in gray matter anyways. And regarding white matter, of course, there are different methods to study, for the DDI and things like that, which would be useful regarding medication effects also. So I think that's a good point that there should be some kind of effects also there.
Regarding the statistics on the meta-analysis, I noticed that there are very, very small effects, like 0.17 or something like that. How do you do this statistic? What goes in there? What are the end numbers? I mean, there are the study numbers, but what do you have some like
can be interpreted. 0.1 is small, 0.3 is moderate, but that's still between small and moderate, which is not so small. In a way, it corresponds to some effect anyway, which is also interesting that these effects are maybe larger than those of illness, at least in some of those studies. But you have these numbers, the study numbers are of course not small. I don't have here slides which list all the studies, for example, about those 3 or 4 studies, in samples they were. But these were mainly from these studies because they look for several areas, and these are a bit larger. And as you can see from the sample sizes, and which is also my conclusion that we need larger studies. And these 2 first ones here are by far the best studies. And also our study, which is only 33, is good because it's quite long follow-up, and in that sense we can also look for different covariates. But that's a good point, of course, and I will encourage more larger follow-up studies and long follow-up studies also. That was a good comment.